Good afternoon, everyone, and welcome to the webinar that will feature today, where we will focus on advancing maternal health equity. The subtitle for that, Coming Together to Support Mothers in the Workplace. This is a very important topic, and we have a very esteemed panel who I will introduce here shortly, who will be answering questions that I will pose to them and taking questions from you as well. So we're very excited to be with you today because, again, this is a very important topic, and it gives us an opportunity to look at how we can address maternal health disparities and inequities and move towards more equitable delivery of care for mothers and birthing people across the healthcare system. It also gives us an opportunity to take a deeper look at what are the real root causes of disparities and inequities, and what are the potential solutions or avenues that we can take to address disparities and inequities in healthcare, and in particular in maternal healthcare. So we will take the opportunity to walk through the whys. We will also take an opportunity to walk through what can be done in partnership between employers, health plans, community organizations, and other key stakeholders as we try to move towards more health equity and maternal health. So it is an exciting time for us to have this discussion, and we are looking forward to getting into it with you today. Now let me take a moment to introduce that esteemed panel that I referenced earlier. And some of these folks are old family members, and I told them I wouldn't say old, but I mean long-term family members, so excited to introduce them. And then we have a new person who's really an amazing addition to our family circle. And so joining the panel, we have Stacia Cohen, who is the Executive Vice President of Health Services at Care First Blue Cross Blue Shield. We are very excited to welcome Stacia, so welcome, Stacia. Also joining us is Stacy Stewart, who is the President and CEO of the March of Dimes. Stacy, always a pleasure to have you on the line, and so welcome as well.
Thank you, Reed. Great to be with all of you.
Oh, absolutely. Thank you so much. Thank you both. Rounding out our panel, we have Brenna Chabel, who is a Vice President for the Business Group on Health. So welcome, Brenna.
Thanks, Reed.
Welcome to you all. Now we're going to get into a conversation with you, as I mentioned, where we'll have an opportunity to ask you some questions and hear from your vast experience and learn what things you are doing and what things you think we could do to address disparities and inequities in maternal health. But before we do that, let's get started with some background and some framing to set up the discussion. What we learned in our conversations with employers is that there is not a lot of familiarity with the crisis that exists in maternal health care in terms of disparities and inequities. The awareness and familiarity are very low, and this slide really tells the story here, where we've asked how familiar are you with the crisis, and you can see here the national maternity health crisis, 8 out of 30 existing maternal health disparities, 11 out of 30. The data are telling in terms of the need to raise visibility for employers and employer groups as it relates to the disparities that exist. We also see here that when you ask the question, do you foresee maternal health equity being a focus of your organization in the next year, again, the numbers are telling in terms of yes, 9 out of 30, no, 6 out of 30, unsure, 15 out of 30. So we have an opportunity to, again, raise visibility, if you will, as it relates to the crisis that exists in disparities in maternal care. I want to move on and share with you that we had an opportunity to not only get numbers, but a quote that we found telling in terms of talking to an employer about their awareness about the crisis in maternal health. And I'm going to read this to you because it was a telling but also important realization when we had this conversation. And the quote is, "I am not aware of the maternal health crisis, so this is not high on our radar. However, we do recognize the health inequity that exists surrounding maternal health and available resources. And that was not a one-off quote. We heard that from several employers as we reached out. So it is definitely an indication that there is a need to raise visibility, if you will, as it relates to the crisis that exists. I wanted to also share with you that Blue Cross Blue Shield is taking particular action, but I'll share that with you in a minute. One more fact point that I'll raise for you is that we've seen that there is this is broadly affecting the workplace in terms of our large employer-sponsored healthcare groups and the cost that is associated with the health plans that they support. And you can see here that in terms of the data that we collected, a majority of women in the workplace will become mothers, right? The data is really telling that we're going to see more and more women in the workplace becoming mothers. That 50,000 women suffer life-threatening pregnancy complications each year. Again, the data are staggering. The prevalence of delivery complications is 46% higher among Black mothers versus white mothers. Employer-sponsored health plans cover 1.9 million deliveries. And I think this last point, it really resonates in terms of the impact that we can have if we take action. That we could see if we had a 9% drop in unnecessary cesarean sections, we would achieve a $1 billion savings annually. $1 billion annually. It is really staggering. And that is just one factoid that we can use in terms of not only improving quality of care, but also reducing the cost of care as well. As I referenced a second ago, Blue Cross Blue Shield has taken some particular defined actions around health equity, and in particular, maternal health disparities and inequities. And almost a year ago to date, we launched a national strategy that's focused on improving health equity. Right out of the gate, we said that we wanted to focus on maternal health and improving maternal health. And so we launched a bold public-facing goal to reduce racial disparities in maternal health by 50% in 5 years. This bold goal gives us a stake in the sand to work from, but it also helps us in terms of framing out that larger health equity strategy that will focus on advancing things that reduce disparities and inequities across the care continuum, and in particular in maternal health. So we're very excited about the opportunity to advance that healthcare strategy, but we do understand that we cannot do that alone, and it's going to take partnerships across many different stakeholders to ensure that we are reducing racial disparities in maternal health. So we look forward to continued collaborations in that regard. I want to keep moving in terms of the fact that racial disparities, and in particular racial disparities and maternal health disparities, are not a new thing, right? We just had a very bright light shined on it over the last several years with the death of Mr. George Floyd, the calls for racial justice across the country, the impact of the pandemic on people of color, the disproportionate impact on people of color. So there's a very bright light shining on health equity, and in particular maternal health equity now. But this is not a new situation. And it gives us an opportunity to look at, in greater detail, what are some of the root causes and things that have led us to where we are now. So let's start with our panel and engage them in a set of questions that will allow you to hear from them and their wonderful expertise in this regard. And let me start with a question, and I'll pose it to a couple of you. What disparities are women of color and other diverse segments in the workplace facing throughout specific phases of a maternity journey? And why is it crucial to address all phases of maternal health? Stacey, I'll start with you. And again,
That's great.
welcome.
No, thank you, Reed, and it's great to be here with all the other panelists. And what a great framing of the issue today, and very telling that it's clear we have a lot of awareness building and a lot of education to continue to push forward on to make sure that everyone's aware of the issues that moms and babies in this country are facing. So thank you for the opportunity. All of this work is really at the core of what the March Times is about. Our work is all around healthy moms and strong babies. And, one of the things that we're very concerned about is not just improving maternal and infant health overall in general in this country, but making sure that we're making a difference to eliminate those health inequities that you talked about. And it's also why we're so thrilled to be in partnership with Blue Cross Blue Shield and be supporting and working in partnership with you on this public goal to reduce racial disparities by 50% over the next 5 years. We really are very grateful for you all taking such a strong stand in that space. But I think there is a lot of maybe misunderstanding or just a lack of understanding in general about why these disparities, these inequities exist in the first place. And to your point, Reed, this is something that's been in the making for hundreds of years. I mean, I would just ask anyone that's listening, when can we recall a time in this country when people of color generally, certainly the formerly enslaved or the descendants of the formerly enslaved, had access to the highest quality health care in this country at any point in the history of this country. When you look at the time of slavery, it didn't exist there. When you look at Reconstruction, it didn't exist at that time. When you look at Jim Crow, it didn't exist in that time. I was born in 1964, the same year the Civil Rights Act was passed. We began desegregation of public hospitals and things like that. I served on the board of Grady Hospital for 7 years. My father helped to desegregate. My father helped to desegregate Grady Hospital. But we still have in this country a lack of access to coverage and a lack of access to quality care. And we see it in a number of ways. We see it in the number of women especially and people in general who are uninsured still, even with the Affordable Care Act in place. We see it in terms of many women of color, Black women, who express that they don't feel that they are respected or listened to or heard by their healthcare provider. In fact, when we look at the issue of maternal mortality and morbidity, even the CDC has said that 60% of the cases of maternal mortality could be prevented if women were responded to in a timely manner, diagnosed in a timely manner, and if their needs and their symptoms were treated when they expressed that they were having those issues. So we know that there's an issue of a lingering legacy of racism and discrimination that is still creating a lot of the challenges in terms of women of color accessing high quality care. And we know that just a flip of a switch doesn't remove those things from the system. And we also know that as it relates to interpersonal dealings, that interpersonal implicit bias is still a major issue. I'll give you an example. We work very closely with a lot of families that have been impacted by the death of a loved one or a near-death experience. And by the way, I would want to point out, when we look at the issue of maternal mortality, we are talking about a little over 800 women that died as a result of pregnancy and childbirth in this country last year. Doesn't sound like a really big number, but here's the real issue. Our maternal mortality rates have more than doubled over the past 25 years. We're the only highly developed country where our maternal mortality rates have been increasing, whereas every other highly industrialized country's rates have been declining. And when I look at those individual personal stories of folks that we deal with, a guy named Charles Johnson, who some people have heard about, whose wife Kira died after having a fairly routine C-section. Her needs were unmet for hours, a CAT scan not received for hours. Her vitals ended up declining. She ended up being then rushed after hours, after not being paid attention to, rushed into the ER. When they opened up her abdomen, she had 3 liters of blood. She was allowed to bleed internally for hours, even though her husband at her bedside had been pleading with the hospital staff for her to be paid attention to and looked at. She died unnecessarily simply because she wasn't being responded to in a timely manner. These issues become very personal. We can look at the data and the big numbers and understand that maternal mortality is what it is, that Reed, you pointed out that 50,000 women have near-death experiences, not just the number of women that die from pregnancy-related causes, but the number of women who come close to death is particularly concerning. But these issues then get down to the very personal level. You know, a father today who is raising his kids by himself because his wife, his spouse, his partner is no longer here. So at the March of Dimes, what we try to do is deal with the level of the issue at the population level, with policy change, dealing with the systemic failures that are causing these issues. But then we also deal with the families themselves and the very personal challenges that they're facing simply because the system is really failing them. And it's absolutely failing Black and brown women far too often. And that's certainly what we have to address in our work together with Blue Cross Blue Shield, but with all the partners around the country, employers, other health plans, policymakers, and others.
Stacey, thank you so much. Well, really insightful and just really amazed by the work that you and your team advances from March of Dimes. And so we'll hear a little bit more from you later, but I want to turn to Stacia now. And Stacia, from a health plan lens, right? Vast experience, and I know that you are doing amazing things from Care First, Blue Cross Blue Shield. Let's hear from you on why this is a critical topic.
Thanks, Reed. And Stacey, as usual, you're a tough act to follow. I would say, right? This is so part of your the air you breathe every day, that kind of genuineness really comes through. So thank you for that. One of the things I might add to your comments is that averages lie, and that we will continue to see, wider and wider impacts on affordability, access, equity, and quality if we can't figure out how to move the needle on health disparities. And this is one of those places that really rings true. Complicated deliveries, complicated pregnancy outcomes, poor fetal outcomes, sick babies, mothers who are suffering and having unnecessary cesarean sections or complicated deliveries, that all costs a whole lot more. And that continues to widen and increase the challenges that you were talking about. So as healthcare gets more unaffordable, it leaves more and more marginalized populations behind. And so as we look at how do we meaningfully improve that, and how do we get to an accessible, affordable, high quality, equitable healthcare system, we can't just look at the averages. We have to look at the data underneath the averages, because it's going to continue to require diligence in some populations. And I think that this is one of them. The other thing that I might tack onto that you alluded to was, that we're going to have some continued work to do on cultural norms, on cultural bias, on implicit bias, and frankly, on trust building. As a healthcare ecosystem, there is frankly some reparative work to do, whether you're a payer, whether you're a provider, whether you're somewhere in between, whether you're a plan sponsor. There's in places, as you described, some well-earned mistrust. And so I think part of our work together is going to have to be not only looking at the data, not only looking specifically at how do we address the things that the data tells us, because we can't fix what we can't tell ourselves the truth about, right? I think every day when I get on the scale, oh dear, I can't fix what my weight says unless I actually tell myself the truth about what that is, right? I can't improve my physical fitness and, how fast I run if I don't measure it. And I think that this is an area we continue to have a lot of work to do. And I think that part of trust building will be sort of incumbent in that body of work as well. The only other thing I would add before I turn it back to you, Reed, is that we also have a tendency as a healthcare delivery and payment system to treat people in more and more and more specialized little chunks, right? the specialization of modern medicine has brought wonderful advances. It has brought amazing treatments. It's brought all kinds of really good stuff. One of the things it's also brought in its wake is that everything has gotten more and more specialized. And the burden of connecting all of the dots in the ecosystem of health now fall to the people who need healthcare. And so when I think about that in terms of pregnant women and pregnant people, we bring our whole health to the table when we're expecting. We bring all the things that happened before we got pregnant, all the things that happened during our pregnancy, and quite honestly, all the things that happened subsequent to that if we have more than one child. And improving that entire ecosystem is necessary. We can't focus on just one sliver of that, or we will continue to widen health disparities. And when we do that, we impact affordability. And by affordability, I mean to households and to employers, and that is the relative cost of care compared to all the other things they need to spend money on. It isn't just a measurement of what does, on a unit cost basis, procedure or service XYZ cost. It's what does that cost in relative to all of the other things I as a business, I as a household, I as an individual may need to be budgeting for. And so as we, as we face that in our country, these are the kinds of places that if we can get honest about it, we can actually drive improvement that impacts access and affordability for everybody.
Great. Stacia, thank you so much. I think Stacey and you did a really nice job of kind of flaming up some of those underneath why this is critical and crucial. But I want to click in a little bit, if I may, and Stacey, we'll stick with you, and then Brendan would like to bring you into the conversation. Clicking into some of those root causes or contributing factors, are there additional things that you would point out, Stacey, and then we'll go to Brenna around key or contributing factors?
Yeah, no, it's a great question. And I want to pick up on a point that Stacia raised, which is, I think this is a good reminder that our health and wellness is not primarily determined by what happens in the doctor's office. And that certainly is true for women, for pregnant women and pregnant people. Our health is primarily determined by how we live. And to the extent that many Black and brown people in this country are living in communities without access to safe, decent, affordable housing, without access to good nutrition, living in food deserts, living in what the March Times has done research on, that's called maternity care deserts, places in this country that have a little to no access to obstetric care, living in stressful environments can contribute to a decline in overall health. And I think that the effects of racism and discrimination that many Black and brown people have to live with on a daily basis, again, are some of those social determinants that actually have, a negative impact on our health and explain a lot about some of the underlying causes of these disparities. But I also want to say a couple things. One is that when we look at the issue of maternal health, it's really important to not just think about the time of childbirth or even the time of pregnancy, that when we talk about maternal health, we believe very strongly that the health of women before they're pregnant, certainly during pregnancy, and even in the postpartum stage are super important. In fact, when we look at maternal deaths, about a third happen during pregnancy, about a third happen at the time of childbirth, and another third happen 1 week after the baby is born out to 1 year. And so it's that life course that we are really looking at. And it's really looking at even the health of the woman, whether or not she has chronic health conditions, whether or not she's affected by diabetes, hypertension, and other chronic health challenges even before she's pregnant. Another issue that I just want to raise too is there's been a lot of research on this idea of what's called maternal weathering. It's the idea of how stress and anxiety over time can biologically impact one's own health. And what we see in women of color is that effective weathering actually has a direct impact on whether or not they are able to maintain good health, maternal health, during pregnancy and even in the postpartum stage as well. So there are a lot of very complicated underlying causes, but at the root of it, what and what's explaining these disparities, Reed, really comes down to the effects of racism and discrimination in communities of color over a long period of time. And Stacia made a good point. These are not things you could just flip a switch on and all of a sudden they get better. It took us hundreds of years to get to this issue and these challenges. It will take us a long time with very concerted effort to equal the playing field and level the playing field for many communities of color, affecting many women of color, so that they can improve their health outcomes over time. And the last thing I'll just say about this is that it's not just an issue of the moms, because what we see at the March 9s is that having a healthy baby really stems from whether or not the mom is healthy. That so much of what we see in terms of premature birth and issues around infant mortality and the disparities that exist there really are in many ways largely driven by the health of the moms in the first place. And so this issue of the mom and baby dyad is super important as well. And that's why not only do we see disparities with maternal health outcomes, but we see it in terms of infant health outcomes, with Black babies having twice the rate of infant mortality dying before their first birthday as compared to white babies. So it's really a bigger issue. It's important to talk about mom and baby health together.
Right. Stacey, thank you so much. Brenda, I want to bring you into the conversation, and you and your organization have a unique viewpoint and lens into this. So what do you see as some of the underlying factors, the root causes for the disparities in maternal health?
Yeah, thanks, Reed. And for those of you who aren't familiar with Business Group on Health, we're a large employer membership organization. And my job specifically at the Business Group is that I support all original data collection and research. So whenever I'm approaching a problem that employers are trying to address, particularly new problems to them, I always want to start with data. So I'm going to apologize. I'm going to hit you all with a lot of data, but I think it's really important as you start to uncover ways that you as an employer and your partners can really focus on maternal health disparities and how your company can address it. So Stacey had covered a lot of things that I had on my tick list is important to cover, but I can support some of it with a little bit of data. So the weathering that Stacey had mentioned, it's actually related to, experiencing racism and prenatal stress. There is a linkage to those adverse health outcomes. We know it can have an impact on low birth weights, preterm delivery. So that is an area, again, it's not necessarily just focused on what's happening at the provider's office, it's the overall experience. But then when we drill down to provider bias and provider treatment, this is a really important area to look at as well. So we know that a third of Black people report being discriminated against at the doctor's office or at a health clinic. And that really feeds into what was mentioned before by the other panelists, is that it feeds into this distrust or feeling like they're not being heard. And that could result in a lot of individuals not continuing to seek care. We know how important it is for pregnant women to receive prenatal care on schedule. And so if there is that negative experience in the background of not getting the treatment that those individuals deserve and need, they may not be pursuing care as needed. And then when we think about specifically the treatment that is provided to Black individuals, this is a really important statistic which may not be new to a lot of folks, but Black patients are 40% less likely to receive medication for acute pain compared to other white patients. And that's a really important statistic. I think we can all agree pain management is important in the maternal health journey. But what that does is that could potentially, result in folks not asking for a test or specific treatment or pain medication. So I think it really goes back to what we heard before of the importance of providers and everyone supporting women in their journey, listening, not being dismissive of their specific needs. We know that dismissing pregnant women's needs is definitely occurring, and more so for Black women. And I know we have a lot of content to get to, but one other area that I did want to mention, and I will bring up later on, is the importance of access. And access means a lot of different things for this population. One thing I did want to point out is really related to access to different benefits, whether it's infertility benefits, basic healthcare coverage. of those who are along their pregnancy journey. And we know that BIPOC employees in the US have less access to employer-sponsored healthcare coverage and programs. And so that is really the area that we focus on, is the fact that this community is overrepresented in hourly non-exempt positions that are sometimes not eligible for benefits, like, again, infertility services, different healthcare benefits. So when I talk to employers about this issue among equity, think about those hourly employees as well, because we know that the BIPOC population is overrepresented within that group. And I just close with this also. We know that Black people are more likely to experience life-threatening conditions during pregnancy, preeclampsia being one of those, that Black women experience signs of preeclampsia actually earlier in their pregnancy, more so than white women.
Excellent. Brenda, thank you so much. And for my wonderful panelists, you are a wealth of information. We're going to try to move this on a little faster so we can get to all of these questions I want to ask you. But really appreciate what you bring to the table, because I think the folks on the webinar are hearing just how important this topic is, and how it's going to take all of us working together to address all of the issues that you all raised. And you focused on it through a health outcomes, health quality, health of the mother, health of the child, health of the family lens. I want to take a moment and focus on it through a cost lens as well, because it's an important factor that's also relevant here. And so, Stacia, when we think about cost and associated in maternal health, what are some of the things that come to mind for you that employers can work on, and even in collaboration with health plans, can work on to address rising costs in this space as well?
Sure. So I think Stacy mentioned the rising C-section rates, and Reed, you talked about a 9% reduction in C-section, voluntary and elective C-sections, would result in $1 billion in savings a year. I think about the associated suffering that goes with surgical procedures that wouldn't be necessary either. I would also say there's a significant cost delta between vaginal and cesarean section deliveries. So not only is there a health outcome, right, impact, and a quality of care impact, not to say that C-sections can't be safely and effectively done. I would not want to be disparaging in that way at all. But let's face it, some of this is driven by us as professional women wanting to schedule our deliveries at 2 o'clock on Friday afternoon, right? Some of this is driven by the medical community and by some of the kind of biases that Stacy talked about. But the reality is that it is a more expensive way of getting care, just like heart surgery or getting bypass grafts put in is a more expensive way to treat high cholesterol than a healthy diet is, right? And the impacts of that. And I don't say those blithely or lightly. I just use examples that, that have relatively big differences in cost that can help people see that. Sure. One of the things, though, that Brenna mentioned that I'd like to tag onto around the access to coverage and support services, that flies a little bit in the face of as I talk about this, you'll say, well, that could drive more cost, but I think it actually drives more effective outcome, which in the long run drives more effective costs. We tend to think at scale. As employers, what can I offer my whole population of employees, right? How do I get something that fits for everybody, that supports enough of folks as employers, right? We do the same thing as healthcare providers. How do we take evidence-based practice and do that at scale and offer the exact same thing to everybody, right? Because that is more cost-effective to deliver. Unfortunately, the outcomes aren't as consistent then, because one size actually really doesn't fit all. And that was one of the things that I really heard Stacy talking about, is that While we have certainly made strides in both maternal and infant health in the United States over the last 50 years, that is not equally true for everybody. And so as employers are looking at how do I offer coverage, affordable coverage to my employees, and how do I provide supports and services to them, I would also encourage us, if we're really serious about cost, that we don't think about just one size fits all, because I don't think we're going to drive the same kinds of outcomes for that. The other thing that wasn't mentioned in this ecosystem that helps produce healthy women, children, moms, babies, right, is how much time do we spend on our feet? How much time, especially during pregnancy, how easily not only do we have access to coverage, but do we have access to the time off to, in fact, to go make those appointments and get the kind of prenatal, intranatal and postnatal care that we need. And I do think that not only is access to coverage a barrier, I do think access to time off continues to be one, even in an insured population.
Great. Stacia, thank you so much. Brenda, anything that you would add as it relates to cost associated with maternal health disparities?
Yeah, I would say, I kind of think about it in three direct ways and one slight indirect way, which Stacia covered most of them. But first, the human toll, the costs of not addressing this, both from a morbidity and mortality standpoint. We know that in 2020, the gap within these disparities, maternal health disparities, was widened even more during the pandemic. And so, keeping an eye on that as well. The emotional toll, the trauma for the families, coworkers, loved ones when these things happen. Healthcare costs, as Reed said, 1.9 million deliveries covered by employers. It's in everyone's vested interest that women have access to high quality infertility services, obstetrics, and that their needs are being met. The one area, though, that we're really beginning to cover and investigate more is the impact on employee value proposition. So standing up for health equity, advancing health equity should be a standard among employer companies. It's a human and moral obligation. And if a company doesn't pay attention to that and focus on that, your employees may sit up and take notice. So making sure that that's taken into account when you think about your EVP.
Excellent. Now we've talked about and framed up the problem, right? And we've even looked at some of the impact that we have not only on, again, mothers and babies and their families, but also on the workforce as we look at maternal health disparities. I want to shift our focus now and look at some potential actions to address these disparities and even solutions that you all might recommend in terms of addressing disparities and inequities in maternal health. So as we think about this, we still hear that employers are only somewhat familiar with the existing maternal health disparities in their organizations and feel challenged about what things they can do to further identify or address such disparities. And you can see here some of the challenges: identifying disparities, feeling confident that disparities will be clear when they arise, reaching the appropriate audience, having the time and resources to place a focus on this. All things that we're hearing in terms of challenges. On the right side of the slide here, you can see that health plans are really interested and focused on how we can partner with employer groups to help with these particular challenges, and focusing attention on helping to identify current and potential future disparities, helping to provide better access to care across, as well as resources in remote areas. So not just an urban issue, but also a remote or rural issue as well. And then providing data to make it easier on employers. So all things that we are seeing as opportunities for collaboration or engagement between employer groups and health plans. Blue Cross Blue Shield, in addition to the work that we're doing that's is being guided by our health equity strategy and our focus in particular on maternal health, we identified an opportunity for us to elevate information and resources that would not only frame the issue, but create a top 10 list of actions that can be taken to improve health equity or address disparities and inequities in maternal health. I will not read all of the top 10 here. This will be shared in the material, but it goes to say that there are opportunities for, again, collaboration and engagement, starting with an opportunity to just identify what the problem is. We heard that there's a lack of information or familiarity with the extent of the problem. And so not only elevating information or amplifying information about the fact that there is, but working with your community leaders and other stakeholders, health plans, working together with employer groups to address these issues. And so this top 10 gives you sort of a springboard to things that you can do, actions that you can take that will have lasting impact on maternal health equity. So we're excited about the opportunity to share that with you. But as we move forward, we wanted to continue to frame up the discussion and ask some particular questions that relate to what headway has been made in an effort to advance maternal health equity and what challenges still lie ahead. And so how can health partners show their commitment? And Brenna, I'm going to start with you in terms of how can health partners show their commitment to advancing health equity in maternal health.
Yeah, sure thing, Reed. So let's go to that next slide because this is some data that I want to pull forward. So I'm going to talk specifically about what some of our employer members are doing related to addressing health inequities within fertility and maternity care. And then I have two other points that's not on the slide that I want to make. Okay, so as part of our large employers healthcare strategy and plan design survey that we do every summer, we asked a series of questions around disparities and inequities. And this was really some very telling information of how employers are looking to address these topics. And of course, none of this can be done alone. Employers are really needing their health plan partners and other vendors to take part in this. So when we ask them, how are you addressing health inequities, the top response, as you can see here, is identifying high-risk pregnancies among under-resourced populations through different services. 47% of our large employer members are doing so. Expanding coverage of postpartum depression services, expanding fertility benefits to include more types of employees along different paths towards growing their family, promoting group-based prenatal care that 24% were doing last year, and certainly that is something that we do see some really promising early evidence that can help fill some of those care gaps that we're seeing across the country. Efforts to lower C-section rates, and then covering doula services for expecting parents. And I just wanted to pause with this because this has been something that a lot of our members have been looking towards and trying to figure out if doulas can play a meaningful role. And filling some of the gaps. So one example I wanted to share is a public example from Walmart. They started actually offering $1,000 to individuals, their associates who live in Georgia. Georgia is a state that has traditionally low rates of OBGYNs to provide those services. And so Walmart is providing up to $1,000 per pregnancy for doula coverage. So that is really a nice example of being able to better support employees who could certainly need it during pregnancy. And then the last thing before I'll turn it back over to the panel, I'm going to keep harping on this provider directory and provider networks because it is something that's really important to our business group on health members. And it's not on this slide, but we know that 47% are looking to require health plan and other partners to maintain provider directories with more information to allow their employees to select or better identify matches with providers. And another quarter will plan to do that in the next 2 years. And then on top of that, 39% are working with their health plans to expand provider networks to include a more diverse set of healthcare and mental health providers. So that's not just for infertility or maternal care. That is broadly across the board. So these are things that we're hearing from employees of large employers, that they're looking for more diversity. They want to know how they can best select a provider. But we also see it in the data and the evidence. We know when Black physicians care for Black babies, infant mortality is significantly less. The evidence is there. And then when patients have physicians that look like them, quality of care, satisfaction, and trust all increase. So it can have a very meaningful impact looking at your provider networks.
Awesome. Thank you so much, Brenna. Stacia, I'm going to toss the same question to you in terms of how can health partners show their commitment?
I'm going to piggyback off what Brenna was just talking about. I don't think anybody would disagree with that. Quite honestly, I think that is a huge barrier for people having the kind of relationships with their healthcare providers that will drive the best outcome. Unfortunately, some of the same distrust issues we talked about on an individual and patient basis exist with the provider community as well. And we actually have states in the country that health plans are prohibited from asking that data. Or requiring that information. Now, that doesn't mean some providers couldn't voluntarily give it, but I do think a place of opportunity in partnership between employers and plans and the community is to really get talking about that and be talking about that with our regulators and legislators, continuing to create barriers that would prevent doing that, I think is really problematic. Now, I say that, and I also recognize that there is distrust there. What would we do with that information? If you're asking for my race, ethnicity, or language as a provider, how might you be measuring me differently than you're measuring my white counterparts? Like all of those things are real for every bit as real for providers as they are for patients who are looking for culturally specific and relevant care. But those are some of the challenges that we together are going to have to deal with. So I don't think you're harping at all, Brenna. I think that's a real barrier and one that, frankly, we really are going to have to collectively work on. Data in and of itself, I love that you started this conversation today with data because I think that's one of the largest gaps that we have. Back to the whole we can't fix what we can't tell ourselves the truth about. Race, ethnicity, and language data is not available on claims. In most instances, it's not available on enrollment data. And so to use actual member validated data, because I don't want somebody just imputing what my race or ethnicity is or the language that I speak by my name, right? Lots of people would look at my name and say, oh, Anastasia, she must be Russian. And I'm right. And like, there's a lot of bias we bring just when we're looking at naming conventions unintentionally. And so, I would say getting to the place where we as a system, as an ecosystem of health, can get to a place of trust, with the right kind of governance in place, like who's got the data for what kind of purposes? Are we comfortable that those purposes are for good, right? Is really important work that we all have ahead of us. Otherwise, we are either guessing what works, which clearly has not worked well in this country, or we're telling ourselves something works when it only works for some. And so I think that's an opportunity that we all have. And I see that as a place that plans and partners and employers and providers and communities can work together.
Stacia, thank you so much. And, I'm actually going to double down on that question with you, Stacy, and ask you, how do you see employers, health plans and community partners working together to move towards more equity in maternal health?
Yeah, I think that's a great question. I think there's a huge role that employers can play and health plans, not only, inside the walls of the companies, but outside the walls, right? So I think on one of your slides, Reed, you mentioned, being a part of a perinatal quality collaborative is really a key action. A lot of people may not even know what those are, but those are big collaborations of healthcare providers and others across the state who really look at data, at perinatal data, and really try to figure out how collectively systems and employers and others can work together to reduce those kinds of perinatal outcomes. I think, at the March of Dimes, we are in partnership with a range of different insurers and health plans and employers and community-based organizations in something that we call our Mom and Baby Action Network, which is really designed to bring everybody to the table to talk about the strategies that can be put in place at both a national, a state, and a local level to actually improve maternal and infant health outcomes. And we certainly invite folks to join us. We play kind of a natural role in our space around some of these issues as a convener, and are very accustomed to convening different companies together to really share best practices and center around a common agenda around improving maternal and infant health outcomes. The other thing is on the policy level change. I mean, part of the inequities that we see are really only going to be addressed with substantial policy change. And what we see in this country is a failure for there to be the kinds of supportive policies that would enable women, especially women of color, who've been historically disadvantaged, to level the playing field and get to a place where everyone can access the highest quality care, irrespective of race, ethnicity, where they live, zip code, urban, rural, whatever, wherever they are and whatever stage of life they're in. And so what we would sort of invite folks to and join us on is really encouraging policymakers at every level to enact the kinds of policies that will make a difference, whether that's extending Medicaid postpartum 12 months, which is an important thing to look at, where far too many women get dropped from Medicaid coverage after 60 days of delivering their baby, but they may have extenuating health circumstances that need to be addressed for months and months after the baby comes. We would also really encourage folks to look at policy changes at a state level. For example, we had a big event at March of Dimes called March for Change. We have March for Babies walk events, but we have March for Change policy events and advocacy events where we were able to talk to state policymakers, and we had employers and we had community partners with us, talking to the governor's office and talking to state legislators in Georgia, for example, just a few weeks ago, where we encouraged them to look at extending Medicaid where they had already extended it 6 months postpartum, extending it for another 6 months out to 12 months postpartum. And within a few weeks of us being there for that event, that change was made. And so the power of employers, community-based organizations, and others coming together is really impactful. And I just would encourage folks to really not just get engaged in serving their population or their employees or whomever their core constituents are, but to look at how these issues can be affected at a community-wide level, and especially around policy change, community actions that are collective in nature, like with the Perinatal Quality Collaborative, or even with some of our other activities called Collective Impact and Collective Action collaborations that are happening, where March of Dimes is leading on those as well. There's so many roles that employers and others can play.
Stacey, thank you so much. Yeah, go ahead,
Reed, if I could just tag on to that. Not only, Stacey, do I support that notion that this takes a village. This isn't an individual player in the village that will make a change. That it actually works. We have, for the last decade, supported the Baltimore for Healthy Babies initiative, which was an innovative Baltimore city-wide strategy that really addressed how do you bring plan sponsors, community organizations, public health, employers together to address this. And we've seen a 30% decrease in infant mortality and a 60% decrease in Black-white health disparities in infant mortality since 2009. Not only is it the right way to approach it because it creates sustainable change, it actually has demonstrated that it works.
Exactly.
That's awesome. And Be More for Healthy Babies is an amazing program. So congratulations on that, Stacia, and for everyone in Care First. You all have answered a lot of questions today that really, shine a brighter light on the need to do something in maternal health equity. And For me personally, I have a sister who's expecting her first child any moment now, and so I am absolutely focused on this as a caring brother. And I know that many of you who are listening in have similar situations going on. So what I'd like to do with our remaining moments here is really focus our attention here on, and Stacey, you did this a little bit, so I'm going to flip to Brenna first and see if there's anything that you'd like to add in, Stacia, and then come back to you, Stacey. What are the top 3 things or actions that you would see an employer focusing on, top 3 actions that they should focus on now to address maternal health disparities and move towards equity?
Well, I would say I do have 3 of my own, so I'll go through them really quickly. But I think, promoting and providing a means for employees to access care that is racially and culturally concordant, that they're able to select the provider that's right for them, requiring cultural competency training among providers. That is something that you can work with your health plan on. And then also hear from employees. Again, it's so important for everyone to be opening their ears and listening directly to employees. So conducting surveys, doing focus groups of employees about their experiences, their needs, and their preferences related to inclusive and equitable care.
Wonderful. Stacia?
I probably would have said 2 of those 3 right off the top of my head as well. What I really heard you say is listen, learn, and act, and take action on what we're hearing from employees. I would also say this takes a village, be part of it. Don't just admire it, be a part of it. And then the last thing I would add to that is that this is going to require time, talent, and treasure strategies. Today, we think of this a lot in terms of how do we finance it? And I would encourage us to also think about how do we invest and support Black-led organizations that lift Black experience and voices. And so how do we invest our time and our talent as well as employers? Because I think it will require all 3 to make sustainable change.
Stacey, anything that you'd like to add? Boy, they really covered it. They really covered it. Maybe I would just underscore a few things. One is, those workplace policies that can really be supportive of women and pregnant people are really important. Paid family leave is really important. Pregnancy protection policies are really important. I think the other thing is that we're doing a lot, as you know, Reed, in terms of implicit bias training. Mm-hmm. Everybody has implicit bias. There's not a human being on the face of this earth that doesn't have implicit bias around something, which is why we think implicit bias training, especially as it relates to maternal and infant health, can be incredibly valuable because it will allow people to begin the process of recognizing their own implicit bias and then figuring out the next steps of how to address it. And the last thing is, I think we've got to do more. Eliminating equity isn't just doing, I think, Stacia, you said this so well, it's not just equality is doing the same thing for everybody. Equity is actually when you actually differentiate the help and the support that individuals need based on what their needs are. And that's where we've got to look differently at meeting people where they are, making sure that doula care that is culturally competent is available to the women that need it, right? And making sure that midwifery care can be affordable and available to the women who need it. Making sure that group prenatal care availability is available to those who need it, because it may be those things that are very evidence-based that might be the very things that, if available and affordable and accessible to the right women at the right time, can actually be the right things to improve outcomes for everyone. And that's what's really important.
Thank you so much. I'm going to toss 2 questions out, and Brenna, I'm going to ask you to answer the first one in 30 seconds, and Stacia the second one in 30 seconds. Brenna, how can employers educate and involve senior leaders in creating a culture of awareness to support and supportiveness in the workplace?
I would say, if you're thinking about how you can work with your senior leaders, getting them involved in, what I talked about, the survey and focus group process, trying to hear from them first, and then getting them involved in the process to hear more from employees. So really, again, open your ears to what employees are going through.
Thank you so much. And then Stacia, what questions should employers ask their health plan partners to help improve benefits and strengthen networks?
I would do two things. First, I would ask the question about how do you differentiate culturally relevant care rather than just how do you provide a blanket of coverage that is sort of one size fits all for everyone. And then in terms of improving benefit design, most commercial employers still don't cover doulas, despite the growing evidence, particularly out of the Medicaid sector, that it actually works. I think as we get more and more attuned to what works around the world in supporting healthy pregnancies and deliveries. I mean, the United States is not the only place people have babies. What works in other places that don't have access to the enormous formal medical care system that we have, and how do we lift those opportunities up as well?
Wonderful. Let me conclude by thanking everyone who dialed in today, logged on today for this really important conversation. This could have gone on for another hour, another couple of hours, especially with this amazing panel. And let me thank our amazing panel. Stacey Stewart, you are just a breath of fresh air and a wealth of knowledge, and always a pleasure. Stacia Cohen, you are just fantastic. Every time we're on a call with each other, I learn more and more about you and about the amazing work that you're doing at Care First Blue Cross Blue Shield. So thank you. Brenna Chabot, you are so knowledgeable. Your data points were spot on. So thank you. You're doing amazing work with the Business Group on Health. So really appreciate that. Stacey will continue to work with you in the March of Dimes as we move forward. Want to, again, thank our participants, and we'll keep this conversation going. We also want to make sure that you are aware that we have information available, and please remember to check out our latest mini e-magazines and other resources that you can find at smarterbetterhealthcare.com. This has been a delight to have this conversation, and hope that you all had an opportunity to hear some things that you can take action on back home once you think about ways to address disparities and inequities and move toward more equitable maternal health care. So thank you very much, and everyone have a wonderful afternoon.
Thank you so much.
Thank you.